We are giving a breast cancer seminar, and I'm actually very excited to introduce Dr. Arnold Baskies. Dr. Baskies is a general surgeon and fellowship-trained surgical oncologist with 4 decades of training and experience in general surgery. He specializes in general surgery and surgical oncology. Dr. Baskies majored in biology at Boston University, graduating with highest honors. After obtaining his medical degree at Boston University School of Medicine, he completed his general surgical residency at Boston University Medical Center. He also did a fellowship in surgical oncology at the National Cancer Institute, a branch of the NIH. Maintains an active role in both regional and national cancer treatment programs. He's a past president of the American Cancer Society of New York and New Jersey, longtime chairman of the Cancer Control Plan for New Jersey. He has been appointed and has served under every New Jersey governor since 2000 as chair of the New Jersey Governor's Task Force on Cancer Prevention. And he's also a member of the National Board of Directors in the American Cancer Society. Everyone please welcome Dr. Arnold Baskies.
Thank you. I'm a little embarrassed. Accolades. I'm reminded of the fact that behind every successful man is an amazed mother-in-law. So, you know, I was introduced as a surgical oncologist, and just to give you some familiarity with the different branches of oncology and what the differences are, I'll give you a tangible example. A medical oncologist, a radiation oncologist, and a surgical oncologist are approaching an elevator. I want you to picture this in your mind. The elevator door is about to close. The medical oncologist thinks to himself, you know, I'll put my foot in the door because I have to write orders for my patient. The radiation oncologist thinks to himself, you know, I'll put my hand in the door because I have to walk between patients in the radiation oncology unit. And the surgical oncologist thinks to himself, you know, I need my hands to do my surgery, I need my feet to make rounds, I'll put my head in the door. And I'm a surgical oncologist, so that gives you an idea of where I stand. All right, so here's some basic information. This is the type of thing that epidemiologists and those of us who are interested in population health look at. This is a listing of what people in the United States die from, okay? So if we look at the slide carefully, you'll see that heart disease takes about 600,000 people a year. Cancer takes almost the same number, about 500, this is as of last year, about 577,000 people die every year in the United States from cancer. Then we have the next thing, the next biggest thing down is cerebral vascular disease, a stroke in other words, which accounts for about 167,000. If you look at the numbers, clearly heart disease and cancer account for about 63% of all the deaths in the United States. Accidents are way down, 2%, even though we hear about it every night on the nightly news. You think thousands and thousands of people are dying. In terms of numbers, it's a small number compared to the number of people that die every year from cancer and heart disease. Then we have other causes of death such as Alzheimer's, diabetes, kidney disease, influenza, and suicide. Suicide's about the same number as accidental deaths in the United States today. Okay, so the reason I showed that slide is there's a study that was done asking Americans, what do you fear the most? What is it that you fear the most? And looking from the bottom up, there are fearless people who don't fear anything. 12% of the respondents said they didn't fear anything. 9% said they feared all of these things. Then we go up from the least to from the lowest to the highest. Being a victim of a terrorist attack. I have a sister-in-law who won't travel outside the United States because she's afraid all the terrorists are after her. A victim of serious crime, being a serious car accident victim. But the number one thing that Americans fear the most is developing cancer. Okay? Notice that heart disease isn't even on that thing. All right, so this is another version of that same slide, but now let's look at what the government thinks we should be spending on cancer. Even though 30% of the population fear cancer the most, we spend $5 billion a year for NCI research. Now, the United States budget, doesn't even make up for, 1 minute of spending of the United States government today is $5 billion. It sounds like a lot of money, but when you think about all the research that needs to be done and all the advances that we can make in the United States today, That's a very small number, ladies and gentlemen, $5.2 billion. It's not a lot of money at all. So they asked the question, how much would you be willing to spend? And these are the numbers. Interestingly enough, about 75% of people who responded to this questionnaire said that they will be willing to spend $8 billion a year. 63% said they'd be willing to spend $10 billion. About half of the respondents said they'd be willing to spend about $15 billion. And about 40% of them said they'd be willing to spend about $20 billion. And there were people committed enough at the rate of about 46% that they'd be willing to spend any amount, even if taxes needed to be increased. So you can see about 40 to 50% of the people don't think we're spending enough money on cancer research in the United States. Okay, so this is a poll that was taken by the AACR, the American Association of Cancer Research, asking the question, what are the odds that you will develop cancer during your lifetime? Do you ever wonder about that, anybody? I do. Okay, so about half of the respondents felt that they had about either a 1 in 100 chance or 1 in 1,000 chance, somewhere in that range, of developing cancer during their lifetime. But the real number is much lower than that, much higher than that, rather. It's 1 in 2 or 1 in 3, as I'm going to show you in a minute. All right? So this is the risk of developing cancer during all of our lifetimes. This is a lifetime risk of developing cancer. And the risk obviously goes up as we get older. It's very low under 40, but as we get older, you can see what the lifetime risk really is. And the lifetime risk is about 47% of men will develop a cancer, and about 38% of women will develop cancer during their lifetime. Now, in point of fact, that number is wrong. Does anybody have an idea of all men age 70, what percentage of men age 70 have prostate cancer? Anybody know the answer to that question? What percentage? If I took 70 men, I took 100 men age 70 and brought them in this room right now, how many of them would have prostate cancer? Anybody want to take a guess?
58.
So 58%. You're pretty close. It would be about 70%. About 60% of all men age 60 have prostate cancer. 70% of men age 70 have prostate cancer. 80% of men, roughly speaking, age 80 have prostate cancer. Now, men generally don't die of prostate cancer. They usually die with prostate cancer. So the reason I mention this is it's going to affect some of the slides later on, is you've been hearing a term, if you've been paying attention recently on the news, to a term called overdiagnosis. Have you heard that term yet? Mm-hmm. Did you wonder what it was? It bothers me a lot because it makes people think that doctors are doing too much diagnosing. But in point of fact, it's recognition of the fact that there are many cancers out there that we actually die with rather than die from. Now, we all, unfortunately, have been touched by the disease because it's common, but I want you to remember that when you hear that, because our goal in medicine is to discover things early in their development. Not necessarily early in time, but early in their development. And so the term overdiagnosis kind of works against us because it makes people think that we're doing too much to try to cure cancer. And I happen to feel that as a person that's been doing this for most of my adult life, that's not what I'm after. I'd like to prevent the disease. And that's what a good portion of this talk is going to be about. All right? All right, so here's another interesting slide, and the reason I show you this is because we all have these thoughts that go through our mind, and sometimes it makes sense to look at this. So this is a slide that shows the answer to the following question. How confident are you that a particular factor increases breast cancer risk? All right? What are the things that increase breast cancer risk? Somebody want to mention one? Family history, right? That affects your risk of developing breast cancer, right? Age, clearly a disease that as you get older as a woman, that your risk increases, okay?
About occupation.
Occupation, actually that's an interesting one. There is an increased risk of night workers. Women who work at night have an increased risk of developing breast cancer. It's also true that women who wear high heels have an increased risk of breast cancer. It's also true that women who have gooey earwax as opposed to dry earwax have an increased risk of breast cancer. Small but increased. Now, it sounds stupid, doesn't it, really, on this, talking about earwax and breast cancer. But you have to make the following assessment, which is what our genetic counselors do, which is risk does not mean cause, okay? There's an association between the type of earwax that a woman has and her risk of developing breast cancer. There have been papers written on this. And it isn't that the gooey earwax causes breast cancer, but there's some association, it's probably some gene that generally controls how gooey your earwax is and whether or not your risk is increased for breast cancer. But getting back to the serious things, we talk about the age at which a woman first becomes pregnant and has her first, has her first period, and the age at which she delivers her first live baby, okay? Those are some of the major risk factors for development of breast cancer. Then we get into breast biopsies and whether you have atypical hyperplasia. Those are the types of things we look at. But there are a whole bunch of other risks. There are risks that you can modify in your daily life that affect the risk for the development of breast cancer. One of them is alcohol consumption. Alcohol consumption is directly related to the risk of breast cancer. And the more that a woman drinks alcohol, the higher her risk is. There's a real relationship there. And there is no amount of alcohol that's been shown to be safe in terms of breast cancer risk. Now, of course, we all talk about red wine and the Mediterranean diet, et cetera, okay? And so you have to balance all of this kind of stuff. But, you know, the more a woman drinks, the more alcohol she drinks, the higher the risk. Smoking is directly related to risk, and there's been a lot of papers on both sides of this controversy, but I think the best papers have shown that there is an increased risk with smoking and how long a woman smokes and how much she smokes, how many pack years she does. So those are some of the modifiable risks: smoking, alcohol consumption. Do you think that, what about hormone use, birth control pills? Do you think that birth control pills lower the risk of breast cancer? There was a nice study that was done that showed that, and all the studies actually have shown that the use of estrogen does not increase, estrogen alone does not increase the risk of breast cancer. Okay? Now, the American public and Congress, depending on which Congress you're talking about, expect improvement in cancer outcomes. Okay, that's an expectation. Why? Because they're spending $5.2 billion to try to get this disease under control. Remember Nixon's war on cancer, the first president? That has set the bar, if you will, and it was a call to action, if you will, that was originated by President Nixon in the 1970s. Okay? So if you want to know what's going on in medicine, read Fortune magazine. All right, this is what this slide shows. Fortune magazine, by the way, topics. And in fact, there have been improvements in cancer survival. There's been about a 1% improvement in survival since about the year 2000, which doesn't sound like a lot, but when you think about it, 1% is a lot. In terms of if we have 577,000 deaths, you're talking about a significant improvement every year. But from 1974 through the year 2000, there was no change in actual mortality, even though lots of money had been invested in trying to get a cure for cancer, okay? And there was no change in survival for people with metastatic disease, unfortunately, all right? In other words, once the cancer had spread to other areas of the body, there has been no change in survival for metastatic disease, which is one of the reasons why I'm a big proponent on prevention. And you'll see a slide that'll show this later on. Okay, so here's the progress that we've made in cancer. 1935, anybody alive in 1935 in this room? No, yes. In 1935, a person who developed, don't be embarrassed. 1935, if a person had a cancer, any kind of cancer, was a death sentence. Okay? Look at the survival rate with this disease. This is all comers in 1935. Now, that wasn't so long ago, okay? My father was already 16 years old when 1935, and he lived a pretty long life. But in 1935, if you developed a cancer, 80% of people died. Didn't matter what you did, all right? By 1971, we had improved survival rates to about 50%. By 2004, we're at 64%, and right now, roughly about 65% of all comers, of all people who develop any kind of cancer, survive the disease. That's pretty good. That's a pretty good track record, but not good enough. All right, so I wanted to mention this. Is a problem with these statistics is introduced by screening. And I don't want to get into this, but there's a thing called lead time bias. And that's one of the problems we have with the way we detect things today. In other words, if someone has cancer today, they're bound to get either a CT scan or an MRI. But in 1990, 1995, very few people were getting CT scans. MRI didn't even exist, really, for the most part. So we actually detect things at a different life cycle of the cancer than we do now than we did then. So in terms of staging and understanding what's going on, we have a much better understanding. It does affect looking back at old studies, for instance. So there is a bias that's built into all this. All right, so let's look at, we talked about heart disease, right? Earlier on? So look at the progress that's been made in heart disease. The blue bar represents 1950. The light blue bar represents 1950. The dark blue bar represents 2005. And this is the last time that I could get these statistics. All right, so if you look here, look at the tremendous improvement made in heart disease, right? Unbelievable. Look at that. We've gone from 590 deaths per 100,000. So about 590 people per 100,000 were dying of heart disease in 1950. That's when I was a year old. And now, look at this. Only 200 people are dying. That's over 50% improvement, right? Right? You agree? Mm-hmm. All right, so let's look at cerebrovascular diseases. In 1950, about 181 people per 100,000. So if we took 100,000 people, let's say the population of Cherry Hill was 100,000, 180 of those people were going to die in 1950 of a stroke, all right? Now, look at the number. Your chances of dying of stroke are much better, right? Much better odds. But look at cancer. Between 1950 and 2005, we can't show anything like that, can we? We don't have that kind of, that impact. We haven't had that impact. But we're getting there, and you're going to see why in a minute. We needed to do a lot of other things. We needed more science. We needed more Cornell Institutes, to be quite honest with you, and more commitment from the government, which is the biggest source of funding for cancer research in the world, is the United States government. By the way, that's the NCI budget. The government spends many more $1 billion through other agencies of the government. The Defense Department, for instance, is, I think, the biggest spender on breast cancer research in the country. Did you know that? The Department of Defense. You have no idea what goes on in the government. They spend money in ways, and Armed Forces people who are on this call, we appreciate everything you do, but I will tell you the Department of Defense makes a big, big commitment to breast cancer every year. People don't even know. You don't even know. You're not even aware of it. So we need more money for research, and the second biggest, by the way, anybody know what the second biggest donor, supporter of research, other than the U.S. government is? Anybody want to take a guess? It's the American Cancer Society by far. Komen isn't even close. The next closest one isn't even close to the American Cancer Society. The American Cancer Society has given over $6 billion for cancer research since its inception. It's a lot of money. Funded 44 Nobel Prize winners, by the way. Okay, so cancer is probably, I think everyone in this room would agree, is probably our #1 health problem. It's the #1 killer of Americans under the age of 85, okay? 1 American dies of cancer, of any kind of cancer, every minute in the United States. 600,000 people roughly this year are going to die of a cancer. 1.4 million people will develop cancer this year. So 1.4 million this year, 2013, by the end of this year, will have developed some type of cancer, been diagnosed with some sort of cancer, and about 600,000 people, not the same 1.4, but people from before, will die of this disease, this group of diseases, sometime this year. 1 in 3 women will develop a cancer in their lifetime. 1 in 2 males will develop a cancer in their lifetime. $190 billion per year are spent on healthcare costs for cancer alone. That's an unbelievable number. Okay, most countries don't even come close to that for their entire budget. And we're spending close to $200 billion a year. Okay, 1/5 of $1 trillion every year. Okay, to just take care of our people in our own country who develop cancer. The NCI budget, even though we're spending $200 billion a year, is $5 billion. There's something wrong here, folks, right? We're spending $200 billion to take care of people with the disease, but we're only spending $5 billion to try to prevent the disease. These numbers are skewed, right? Yeah. It's a little screwy, all right? By the way, you want to know, here's a true abortion. Okay, this is the advertising budget for cigarettes. What's that number?
16 billion?
Right, $16 billion. We spend $5 billion in the United States for the NCI budget to support cancer research, okay? All right? And we spend this, our capitalist society, which I'm very proud of, be a member of, spends $16 billion a year just to advertise cigarettes and to get children hooked on them. All right? That's the goal. All right, so here are some other statistics. This puts everything in, you're going to see why this is an important slide in a second. Prostate cancer, here's the incidence. In other words, here's the number per 100,000, all right? And here's the number of deaths per 100,000. So prostate cancer and breast. For males, it's prostate cancer. For women, it's breast. And for both sexes, it's lung, okay? Those are the big three. And then we fall off a little bit with colorectal. And then lymphoma. Anybody knows anybody has lymphoma or has had lymphoma? So it's one of the cancers that's increasing, thyroid, lymphoma, right? Melanoma. Those are the three that are actually increasing now. Okay, the rest of them are kind of stable or decreasing, but for them, this one is still increasing for a whole bunch of reasons. So these are diseases you hear about, but look, it pales in comparison to these big three, doesn't it? Right? You agree? All right. Any questions about that or interpreting that slide? All right? Now, I'm going to show you a slide, and this is why this represents why we spend money the way we do in cancer research. This slide, if you don't remember anything else about cancer research and what we're doing in it, I want you to look at this slide. I want you to realize that these four cancers, prostate, breast, lung, and colorectal, account for half of all the cancers. So if we could get rid of these, just four diseases, okay? If we could screen the population effectively, about 60% of people that are eligible for a colonoscopy get it in the United States. The other 40% we don't do anything about. We don't screen with stool guaiacs or et cetera. So we could actually take this number and make this like this if we really wanted to, or if we had some good plan for doing this. All right? Lung, we could eradicate this and bring that whole thing down by doing what? Roughly 80 to 90% of cancers of the lung are the direct result of cigarettes. What's the other 10 to 20% from? Anybody have an idea? You won't believe it when I tell you. It's radon. Radon exposure. Yeah. And this includes, by the way, not only first-hand smoke, but second-hand smoke. Breast cancer, we know we can prevent in high-risk patients, and yet we're not doing it in the United States. We just did what we know how to do well. What do I mean by prevention? Well, we could screen better. We could stop this stupid controversy we're having about whether to screen women under the age of 50. This is the most moronic thing in my lifetime that I've seen in cancer screening. It's this controversy that's been set up by the U.S. government prevention task force on cancer prevention, on breast cancer prevention, has said that we don't screen on women under 50. This is an absurdity, ladies and gentlemen. It's an absurdity from my perspective. But we have this controversy that's going on, and the American Cancer Society says we should screen for women for breast cancer beginning at age 40. The government says no, don't start until age 50. And the reason is resources. We're not going to detect enough women to pay for that particular type of thing, but we could identify women who are at high risk. And if we do that, we could identify those women and we could put them on tamoxifen and try to prevent them from getting the disease. For postmenopausal women, the same thing applies. We could prevent a lot of breast cancers in the United States just from screening and doing the things we know how to do with medicines, either tamoxifen in the premenopausal women or in the postmenopausal women, a tamoxifen or an aromatase inhibitor. You're talking about a pill that could prevent breast cancer in 40 to 50% of those women. And the women that are at high risk, if you're at high risk with breast cancer, and I give that woman a 5-year course of tamoxifen, does anybody have any idea what the risk reduction is from that? Over 80%, about 88%. So if I have a woman who has what we call atypical hyperplasia in my practice, and I have 100 of those women, I can prevent them from getting breast cancer in 89 out of those 100 women, just from taking a pill for 5 years, with a very low risk of any side effects from the pill. But we're not doing that. We're not doing it. So if we just did what we know how to do, we could eradicate a lot of these diseases and make a big difference. We have a very skewed society. We have a society, we have a lot of people who don't want to take a pill. We have a lot of people who are much more worried about the side effects of the pill than what it can do, potential, okay? There's a whole bunch of reasons. Our resources are not being committed in the way they should be. It's really the bottom line. But if we just did what we know how to do, what we know now, I make you this promise, okay? I bet you $1,000, or what did Mitt Romney want to bet? $10,000? $10,000 that I'm right on this particular issue. Prostate cancer is a different issue. It's very difficult to prevent, but there are some things dietarily that men can do. Grape juice, regular grape juice, or red wine every day has been shown to affect it. Stopping the eating, especially among our African American cohorts, of processed meats, especially that are charcoal broiled. Those types of things, those dietary types of things have been shown to be very helpful. There are also some other issues that come up in prostate cancer, but one of the problems we have, but we're getting a handle on it, is we don't know how to screen really well for it. And the screening guidelines are very, very skewed right now. They're not really clear. So stay tuned, but there will be some good genetic tests for prostate cancer and how we can try to at least treat it correctly. Yes?
Back to the changes in the screening for breast cancer. What about, I've heard recently, have a mammogram every other year?
There is data from the Canadians on that. In fact, you remember Hillary Clinton? Do you remember her? You're going to... Hillary Clinton's health plan called for mammogram screening every other year. Were you aware of that? Yes. And it was based on Canadian data. The problem is, and to be honest with you, is that there are papers on both sides of that issue. And a lot of the Canadian data is based on really mammograms that are really substandard. In the United States today, we do digital mammograms almost uniformly. If you saw the mammogram machines that they use in Canada, you wouldn't even have one done. They're really undercapitalized. The healthcare system is very undercapitalized, in my opinion. And so, they don't have MRIs. They have like 3 MRIs or 4 MRIs in the whole country. So they're using orthogonal type, they're using old technology. If you saw the digital, the mammograms I'm doing, that I look at today for my patients are so superior to what we I ever believed could be present because of the digitalization.
So you would be comfortable waiting a year?
For women at low risk, I'm on the fence. If I would prefer a yearly I would
pocket rather than
personally I would prefer yearly mammograms, okay. Good quality mammograms. It's kind of like for a number of reasons. One of which is that I happen to feel that if you can diagnose ductal carcinoma in situ or atypical hyperplasia, I can cure that disease or prevent breast cancer in 99% of those women. But once they have an invasive breast cancer, it's a little bit of a different story. So to me, spending the little bit of extra money is worth it. Now, the reason I showed this slide isn't just for that little spiel I just gave you about these 4 biggies, but recognize that all the other cancers are 50%. But just these 4 are 50%. It's amazing, right? So if you were going to use your healthcare dollars, you're the healthcare planner, you're a Phillies fan, so you need to plan, right? What would you do? Where would you had a limited resources. Would you spend it on CNS diseases, ovarian cancer? Look at this. You hear about ovarian cancer all the time. Look at this sliver. This is the percentage compared to breast or lung. So where are you going to spend those dollars? That's where healthcare planning is a problem, because we have very, very ardent and reasonable advocacy groups out there that have their own disease advocacy. I mean, who can resist that little child with leukemia on St. Jude's every time I turn on television? Yeah. Send us $10, send us $15. And so you know, we have a very generous society. These discussions, by the way, don't occur in a lot of countries. Okay, we actually, in this country, I'm very proud to say we face our problems. We made, you know, what Winston Churchill, you know what he said about Americans? Americans always make the right decisions after they make the wrong decisions. So at least we decide what we're going to do at some point, right? All right, so let's talk a little bit about tobacco. I don't want to get, but I want you to realize this. I want you to take this home with you. Okay, this is worldwide. I'm talking about worldwide. Up here in the United States is down here. Worldwide, tobacco use causes 5 million people to die every year. 5 million, right? 5 million, think about that, 5 million people. We just heard about 100,000 Syrians being gassed, but 5 million people a year are dying worldwide from use of tobacco. The current trends, this is really the scary part. Current trends show that given the tobacco use that's present today, that by 2030, which isn't so far away, it will cause close to 10 million people a year to die every year worldwide. On average, smokers die 13 to 14 years earlier than non-smokers. All right, now let's look at the United States. Cigarette smoking is the leading preventable cause of death in the United States. There's no argument on that. Cigarette smoking is responsible for about 1 in 5 deaths in the United States. That's not from lung cancer, that's from heart disease and lung cancer and other types of cancers, which I'll talk about in a minute. Or about 440,000 people a year are dying from this from the effects of smoking. 400,000 people. That's unbelievable. It's like an epidemic, right? I mean, if we had 400,000 people die of the flu, there would be a hue and cry. But we have 400,000 people in the United States every year that are dying of lung cancer, right? An estimated 49,000 of tobacco-related deaths are the result of secondhand smoke. So if you live with a smoker, 49,000 people who aren't smoking who just get affected by secondhand. And by the way, third-hand smoke. You know what third-hand smoke is? It's smoke that's on the clothes and on the couches of those people that are smoking. Those are as carcinogenic as the smoke is. It's a little scary, right? All right. Now, besides lung cancer, tobacco also increases the risk for cancers of the mouth, the lips, the nasal cavity, the sinuses, the larynx, the pharynx or the throat, the esophagus, the stomach, the pancreas, the kidney, the bladder, the uterus, the cervix, the breast, colon, ovary, and acute myeloid leukemia have all been associated with tobacco.
Chewing tobacco also, correct?
Chewing tobacco, it gets into your system, that's correct. In the United States, tobacco use is responsible for nearly 1 in 5 deaths. So 1 in 5 of people that die in the United States today are dying from the direct effect of tobacco. This equals about 443,000 deaths a year. Tobacco use accounts for at least 30% of all cancer deaths and 87% of lung cancer deaths. So if we got rid of tobacco, we could wipe out 30% of all the people that are dying of cancer in the United States and 87% of people who have lung cancer. This is like a revelation, right? Okay. Cigarette smoking has declined dramatically since the release of the first U.S. Surgeon General's report on smoking and health in 1964. That data, by the way, that showed that smoking is related to cancer of the lung came from who? The American Cancer Society. American Cancer Society proved that. The government depended on ACS data. Up until that data was released from the study, nobody showed that there was a direct relationship. Okay? Even so, about 22% of men and 16% of women still smoke in 2011. So we've got the rates down. It's commendable, but we really need to do better. All right, now here's some interesting points. Tobacco kills up to half of its users. Tobacco kills nearly 6 million people a year. More than 5 million of those deaths are the direct result of use of tobacco, and 600,000 are the result of non-smokers being exposed to secondhand smoke around the world. So we've got a lot of people dying from tobacco around the world, 6 million people, and then you can add another 600,000 who live with them. All right? Nearly 80% of the world's 1 billion smokers live in low and middle income countries. The consumption of tobacco products is increasing globally, though it is decreasing in some high income and upper middle income countries. Go to Ireland today, they've stopped smoking. By the way, Ireland was ahead of us. Ireland, they stopped smoking in the pubs and in public places a couple of years before we took it on. Tobacco caused 100 million deaths in the 20th century. If current trends continue, it may cause 1 billion deaths, 1 billion people, unless we do something about this worldwide in the 21st century. So I'm going to ask you a question. Let's see who gets this right. You get a prize if you get this right. All right. So who is the biggest producer, what company is the biggest producer of cigarettes in the world?
Reynolds.
Okay, he says Reynolds. Anybody say P. Lorillard and Sons? Okay, anybody else want to take a guess? That was a good guess, but it's a wrong guess. It's actually the Chinese tobacco company. Well, this is scary. Wait till you see these numbers. The Chinese National Tobacco Company, which is spelled this way in Chinese, is a Chinese state-owned manufacturer of tobacco products. It enjoys a virtual monopoly in China, which accounts for roughly 30%. 30% of the total consumption of cigarettes is in one country, China. It's amazing, right? And is the world's largest manufacturer of tobacco products measured by revenues. The China Tobacco Corporation, founded in 1982, falls under the jurisdiction of a monopoly in China. This organization is responsible for enforcing the tobacco monopoly in China. China Tobacco caters to its customer base of, 350 million smokers who consume almost 2 trillion cigarettes a year. And some of those cigarettes get overseas. All right? That's an aside. All right, so look at lung cancer deaths. All right? Here's lung cancer deaths in the United States. All right? Red is low, blue is high. What do you notice?
Cowboys.
This is the kind of slides that I look at.
Yeah.
It's the Cowboys.
Well, no, not really. No. No. The red is bad, blue is good.
Oh, you said it right.
I'm sorry. Yeah. Sorry about. I'm sorry.
Red is bad.
Red is bad, blue is good. So now what do you think? Look at the South. Look at the South. Isn't that amazing? There's a lot of red. Huh?
Tobacco.
It's a big crop in Kentucky. We have, by the way, New Jersey has the strongest anti-smoking laws in the United States. There are no waivers in New Jersey. New York, which has a strong law, they have waivers. You can apply as a club or as a restaurant or as a bar for a waiver in New York. In New Jersey, there are no waivers. There's only one workplace in all of New Jersey where it's legal to smoke.
Casinos.
Correct, in the casinos. And we came close to getting that. The Atlantic City Board of Aldermen, or whatever they are, the selectmen, voted against it, and then 2 months later they reversed themselves. But at any rate, so now let's look at another slide. This is breast cancer, folks. Now what do you notice about this? Red is bad, blue is good. Blue is low, red is high. High incidence. Look at this, the industrialized states, look at that. And then you go out to California, right? All right, but down south, it's low. African American women have a lower incidence of breast cancer than Caucasian women do, by the way. Lower incidence, but their chances of dying are higher if they get it, for a number of reasons. All right, but I thought this would be an interesting slide to throw in here. Now let's talk about New Jersey. New Jersey has a population of roughly of about 8.4 million people in 8,000 square miles. That's really unbelievable, right? It's the most densely populated state in the country. We have 1,100 people living in every square mile of the state. Right? We also have 41,000 attorneys. We have 5 attorneys per square mile. You can read into that whatever you want. All right, so I threw that one in there, lighten up the load a little bit. But we have more. We're very proud. We have the most attorneys, I believe, per square mile of any state in the country. All right, so if you need a lawyer, you can find one. We have about 49,000 cases of cancer reported to the State Tumor Registry in 2011, which is the last year that I could get the data for. All right, here's the NCI budget. You can see that from 2004 to 2010, what the federal government, what the National Cancer Institute got funded went up abysmally low, all right? From $4.7 billion to $5.1 billion. That really doesn't even keep up with inflation. Okay, so how do we decrease cancer mortality? Let's get into the heart of, now you have a background. You're all epidemiologists. You're now going to become cancer planners, and you're going to become geneticists in about 10 minutes. All right, so how do we decrease cancer mortality? Well, we need to move from diagnosis and treatment to prediction and prevention. This is what we need to do. We need to move this ball from getting a diagnosis and instituting treatment to predicting who's going to get it, and preventing the disease. If we can do that, then we'll be successful. We'll save a lot of money and a lot of lives. Okay, so this is one of my favorite slogans. The Stone Age didn't end because we ran out of stone. Okay, that isn't why the Stone Age ended. So, where are we headed, and and we're enabled in the process by technology, by all those machines you saw downstairs, for instance. Okay, so in the 20th century, which is over, we had generic approaches to diagnosis and treatment. You went into the hospital, you went to the doctor, you ordered a CAT scan, you ordered an MRI. None of those things are bad. I'm just saying CBC, Chem 20, et cetera, et cetera. Okay, so we had a generic approach to diagnosis and treatment. Diagnosis was based on morphologic and pathologic analysis. In other words, you got a biopsy and they looked at it under the slide, and we tell people what's wrong with them, right? Tissue. There was a lack of systematic connection between research and clinical care. There are really silos in this country. We have the clinicians here and the researchers here. And we've realized this for a number of years. We're starting to commingle those people. Cornell has relationships with clinical cancer centers. And people are realizing but that's the way medicine grew up in the United States. There were the clinicians and the researchers. I was a researcher and I was a clinician. When I was at the National Cancer Institute, I was both. I had a lab and I had my patients on the same floor. But that was a unique situation that doesn't exist in most places. And we also suffered from a slow implementation of changes in the system. That was a problem in the 20th century. But in the 21st century, we are experiencing a rapid change. We're having a personalized, specific approach to patients and their diseases, and I'll discuss that in a minute. The diagnosis is no longer based necessarily on what this pathologist sees under the microscope. It's rather the molecular disease that that person has. What is going on? What are the pathways of that cancer's growth? That's really the questions that we're getting at now, and we're getting at it very, very quickly. There's a connectivity from the bench, in other words, from research to the bedside, in a seamless feedback loop. In other words, what we were talking about earlier today, we have a geneticist here who's going to speak to you, who is looking at what's going on with the patient, feeding that information back. The research is going in both directions now. And there's a rapid implementation of change in the system. And that hasn't happened yet, but it is going to. Okay, so the technological changes that are going to occur are exponential. They're not linear. There's so much going on. Information technology has gotten to the point where if there's research that's being done and reported in England, it doesn't have to be published in a book anymore or in a journal. It's published online immediately. So we have that information. It's unbelievable what a difference that has made. That literally has made. And Ray Kurzweil, who wrote a book called The Law of Accelerating Returns, made this statement, and it's really true. We're not going to experience 100 years of progress in the 21st century. It will be more like 20,000 years of progress at today's rate. And it's unbelievable what's going on in terms of information, the information that is being gleaned and gotten, and with the help of computers and new genomic studies that are being done. Technology accelerates data production, and that then develops into knowledge. Scientific knowledge, listen to this one, will double in the next 3 years. Now, what does that mean? It means that what we know now, all that information is going to double in the next 3 years. It also means that a medical student who's starting in September, started the course of work at Rowan in September, will have to, all that information will be outdated in 3 years before they're out of medical school. That's what that means, okay? It's an unbelievable thing. It's good. That's why we need other people to help us, but it's really true. Scientific knowledge will double in the next 3 years. Biologic knowledge will double in the next 5 years. So what we know biologically about a cancer today, that information about that cancer is going to double in the next 5 years. It's unbelievable. Today, all human knowledge is 1%. All of the things we know, all the things we know as human beings, it's going to double, is 1% of what we will know in 2050. It's scary, isn't it? Think about that. All right, so personalized medicine is a reality. I'm going to discuss what that is in a minute. We're rapidly approaching the $1,000 genome. What is that? It means, actually, it's $100 now. You ever hear this ad on television, 23andMe? You know what that's about? You can send in a swab or some blood, I don't know which it is, but one or the other. And they will look at your genome and what your genes are and what they represent and what diseases you can get. You can do that now for about $100. All right? Large-scale GWAS, where GWAS was the study that was begun in the early 90s. All right? Looking at, that was the government's commitment to breaking the genetic code, if you will, and finding out what all the chromosomes, what all the genes in the chromosomes were responsible for. Research integrating complex layers of cancer biology from gene to clinical outcomes as a whole. This is a reality now, and information technology is removing the limitation of human cognitive capacity. A human being can no longer handle all this information. Anybody have any idea how many data points the human being can handle before they don't factor in another piece of information? For instance, I'll give you an example. You saw a car riding down the street. It was blue. It was 1980. It had beige interior. It had neon. It had what are those lights? LED lights in the front. After that, after 5 pieces of information, you can't. Your mind isn't capable of handling any other information. It just isn't. The average human mind can, about one particular topic, can really factor together 5 points. After that, you can't. You can't do it. It just, your mind just, unless you're Einstein, on average, you can't handle more than 5 data points. Maybe she can, and she can, but I can't. All right, so this is what, in 1990, if you were going to look at your genome, your chromosomes, and see what it would have cost about $3 billion. And there were people that were doing this, by the way. There are some very, very wealthy people who have done this along the line. But you could have gotten this done. Around in here is where some of the really super wealthy people started to fool around with this, and they found a scientist who could do this for them. All right? But look where we are now. It's unbelievable. We're down to the $1,000 genome and less. So the same information that cost $3 billion about your genetics in 1990 now costs $1,000. It's kind of like the televisions, right? Those flat screen TVs. All right, so this shows the same thing. Yesterday, being 1990, it would have taken 8 years to do that genetic analysis to see what your genes really said. It would cost $3 billion. In 2009, it was down to $100,000, and by 2011, you can see the slide a little old, it was down to $1,000. In 2012, it's $100. And you can do this for $100 right now if you want to do that. How many people want to know what their genes tell them? Okay, we'll ask that question a little later on. All right, so here are your 22 chromosomes, and your X and Y chromosome are over here. All right. Originally, the first gene that was linked to a disease directly was macular degeneration. Okay? That's a disease that my wife's family, unfortunately, is inherited. They have a whole bunch of people in her family that have macular degeneration. But this gene on this chromosome, see that little brown box? Okay. So that was the first relationship between a genetic site and a chromosome and a disease. All right? Now look what happened. Suddenly, we have a couple of other ones. Look at this. We have QT interval prolongation, which is a disease that kills people suddenly. We know where that site is. Inflammatory bowel disease. Anybody ever heard of Crohn's disease? We suddenly found out where that chromosome is, where that genetic site is. This is another age-related macular degeneration site. And then all of a sudden, look what's going on, folks.
Wow.
All of your genome has been mapped. All right, this slide shows every known site. You want this slide? Every known site. Here's prostate cancer on chromosome number 7. Here's celiac disease. You know what celiac disease is? Gluten-free diets, people that celiac disease right there. All right. Here's type 2 diabetes. Anybody have type 2 diabetes? There's the gene right there that's responsible for that. Hair color. Breast cancer. Right there. There's a couple of them here. Okay. Freckling and burning. Childhood asthma. Breast cancer. All of these are the genes, and these are the sites that have been identified. So now you say, well, what good is that information? Well, if you know the genetic site, now you can start to work on drugs that will work at certain sites. All right? So we're empowering our researchers and clinicians to integrate increasingly complex layers of cancer biology from the gene to clinical phenotype, and all with the aid of a computer. It requires heavy-duty computerization in order to get this information and to figure out what it all means. You can't do this. Human being can't handle this kind of information. And in fact, this goes back to what I was saying before. If you're going to do proteomics, okay, which is a science until itself, there's 1 million megabytes per analysis. So you really need a computer to do these analyses. The human being's mind, your mind, my mind, is a 200 megabyte machine. That's it. Hate to tell you. These two people are higher than mine. I've lost megabytes. So just think about that. Your mind, your brain, can handle about 200 megabytes of memory. Okay? 200 meg, pretty good sized computer, right? But one analysis is 1 million megabytes. So it just shows you what's going on here. So the GWAS study was done. Information technology is removing the limitation of human cognitive capacity. And so is this. Google and search engines such as this have made it very easy for people like me to access the scientific literature and to figure out what's going on in the world. All right, so here are the things that have to change. We talked a little bit about the need for change, right, earlier on. So in the United States, we have clinical communities. We have consumers or patients. We have care deliverers, and we have researchers. Okay, these are the clinical communities, if you will. All right? Then we have the payers. Who are the payers? They're your friendly insurance company. I know all of you love them. Foundations like this, okay? Or people that support places like this, and the government. Okay, there's a role for government. Then we have the discoverers, the genomicists and the proteomicists, people that can figure out what's going on with the genes. And then we have systems biologists, which is a whole new field. Then we have the IT people with whom we couldn't live without, research infrastructure and electronic health records. And these are all silos, but they're changing. All of these things between Obamacare and all of the changes that are occurring in healthcare are mingling all these things. And so hospitals are no longer hospitals. They're now into prevention and wellness, right? Because they recognize that in order to move this ball, in order to get change, we can't focus on one. We have to focus on populations. Population health is where it's at. And at the forefront of this is this kind of research. Okay, so the molecular basis of cancer, it's very, very complicated. Okay, cancer is not a disease that we used to think of. We used to think of cancer as being something that we could cut out without understanding really what was going on. But we now know, and I don't want to scare you, that every single solid tumor, whether it's colorectal cancer, breast cancer, prostate cancer, lung cancer, pancreatic cancer, we can actually find circulating tumor cells in those people before the cancer is discovered, even if they're stage 1. Even if they have clinical stage 1 disease. In other words, stage 1 breast cancer means that you have a couple of centimeter cancer in the breast. But we could actually show that there are circulating tumor cells in all of those women. All solid tumors. All solid tumors. And I'm not exaggerating here. There's a very nice paper that shows that all solid tumors have circulating tumor cells. So why is it, if you have cells in your bloodstream or in your lymphatic system in all situations, even with small cancers, that people are cured of the disease? Good question. And it's got to do with how your body responds to the molecular presence of that cancer. It's a simple thing to say, but it's a complicated thing to understand. And now we understand, not only that, but we understand that in order to cure that cancer, if it's spread, what we have to do is shut off its ability to grow. And that's what this is all about. It's all about understanding not only where the cancer is genetically on that person, whether they have the predisposition. You can get that from a genetic counselor or from a genetic test now, okay, if they have that predisposition. But we figured out ways in order to stop the growth of those cancers. And I'm going to see a slide about that in a minute. All right, so the future is here, and these are biomarkers. These are the biomarkers that are FDA approved, okay? And the reason this is important is that pharma, or the big drug companies, are no longer looking at trying to create a blockbuster drug, okay? You remember the blockbuster drugs, Lipitor. It's a good example, right? Lipitor is one. Adriamycin in cancer is another. It's a drug that's commonly used to treat many types of cancers. Those types of blockbuster drugs are not what the drug company's looking at anymore. They've figured this out. What they want to do is figure out how to interact or stop the growth of a cancer by stopping a particular molecular pathway. So the way we're treating cancer with big gun drugs, for instance, it still is effective, but it's not the way we're going to treat them 5 years from now. Okay? And in fact, it's not the way we treat many of the cancers now that we discover. What we're trying to do is to hit those types of many cancers with what we call targeted therapy based on the molecular pathway that makes those cancers grow. And the reason that that's successful is we have a marker. These are the biomarkers. CA125, CA19-9, PSA. Okay, these are markers. HER2/neu. Anybody has any? If you've had breast cancer, the three markers that we look at are estrogen receptors, progesterone receptors, and HER2/neu. Those are three markers, and we have drugs that work at sites. So if what we're doing is targeted therapy at those sites. Do you follow that idea? So what you need, if you're going to have targeted therapies, is a target or a marker that you can measure or see that you can interact with or hit. And that's why this slide's so important, because this lists a number of the biomarkers that were approved by the FDA. So for instance, if you know anybody that's had ovarian cancer, one of the things that they look at is CA125. It's a biomarker for the disease. CA19-9 is seen in pancreatic cancer. So what we do is risk stratification based on whether or not you are genetically positive, and a good example of that is BRCA testing. We look at mutations at two particular sites in breast cancer for women who are at high risk, in a high-risk group. There's so-called BRCA1 and BRCA2. That's a good example. So we can actually stratify risk, and that's in breast cancer. All right, so the doubling rate of medical knowledge is rapid. It's every 3.5 years, we're doubling the amount of knowledge that's present. One of the big problems we have is implementation of that knowledge. Look at this. There's an average of 17 years of delay in adopting widely proven practices in healthcare in the United States. Isn't that amazing? So even though a discovery is made and it's important, it still takes a long time. This has changed, and it's because we're dealing with a big machine here. Healthcare is a big machine, and it's a big ship. It's very hard to turn a cruise ship, right? It's very hard to do that. It takes a while. But if you're in a yacht, a rowboat, it takes only a few minutes. But we go through a lot of machinations, but that's changing, and it's changing because of the forces that are present in terms of the payers, et cetera, and the government. So this is a change that has to occur. We have to get this number down. Once we have shown that there's a widely proven practice that works, we have to stop this whole business of delaying its use and get it into common practice. Now, personalized medicine refers to the tailoring of medical treatments to the individual characteristics of each patient. Preventive or therapeutic interventions can then be concentrated on those who will benefit. So what you have to do is figure out what will work in a particular group of patients. I'll give you an example. There's a company right now, this is an amazing story. They will take a piece of live tumor. Okay, so if I take out a tumor from somebody, breast cancer for instance, and I can get it to them within 6 hours, they will implant that tumor into a mouse. And you can say, well, will it stay alive? And on average it does, because these are special mice. These are special mice. These are mice that have been treated, that are immunologically incompetent. They can't respond to the presence of that tumor. They don't have the cells to do it. They've been treated in such a way. So they have a tumor graft that's put on them, on the mouse, and that tumor is now kept alive, even though it's out of the patient. So you say, well, what good is that? I'll tell you what good it is. You can now test different drugs on that tumor, can't you, right? The tumor is alive. You can now do all kinds of tests on that tumor. And you can see which drugs will work and which ones won't. Why is that important? Because you don't hit everybody with a sledgehammer if you don't have to. And now you can create targeted therapies. Now, you say, well, that mouse isn't going to stay alive, is it? It's going to die. Every mouse dies, right? Doesn't have a long lifetime. What they do is they then take the tumor out of that mouse, a piece of the tumor, and transplant it to another mouse. So you have a second generation of mice. So you say, well, what good is that? Well, what if, let me give you this example. We all know people or have had people who have gone through one course of chemotherapy, right? Now, the question is, what's going to be with the second course of chemotherapy, right? What drug do you choose? Well, how do you know that? Well, you could have been testing that drug for the last 6 months to see if it works on that tumor, couldn't you? Right? While that mouse is alive, or the mice are alive, you can now think about your second course of drugs that might work if the first course failed. And we all know people go through a third course of chemotherapy, right? Rather than you now can make an educated choice as to what to give that patient. That is a good idea. Not only that, but you can now do experiments. We know that not all therapies, for instance, for lung cancer, all chemotherapies work on all patients. But we can know if a particular chemotherapy drug will work on that particular tumor if we can test it on that mouse. It's amazing, right? That's here now. That's available now. Now, here's our current practice. And this is a little bit of an exaggeration, but one size fits all. In other words, the way we treat breast cancer is, for the by and large, the same way for every patient. Personalized medicine is defined as the right treatment for the right person at the right time, okay? In one size fits all, it's trial and error. Well, if this works, that's great. If it doesn't, we'll try something else. But wouldn't it be nice if you could figure out what the right treatment was for a particular patient and give them that treatment at exactly the right time? And this is what's being demanded of us as clinicians. So what's driving the movement to personalized medicine? Well, safer and more effective drugs are coming out, faster time to a cure, and cost-effective health care. That's a demand now, not exactly a supplication. So the benefits of personalized medicine are, the goal is, or the benefit is, to diagnose the disease more accurately, select the optimal therapy, targeted medicines, get the doses right, increase safety, reduce adverse drug effects, detect the onset of the disease at the earliest possible moment, shift the emphasis in medicine from reaction to prevention. What a novel idea, right? Increase the efficiency of the health system by improving quality, affordability, and success. So here's what reactive medical care is about. You make a diagnosis, you select a medication, you then switch the drug, and then if they fail that, you switch the drug again. It's very costly, it's trial and error, okay, but it's what we do. And it's worked in a lot of people, but it's not really what we want. What we want is this. We want to know if a person, because of our geneticists, if they have a predisposition to get the disease. We want to screen people so we can figure out who's going to get it. We want to diagnose it promptly. We want to pick the right drug early on, and then we want to go into a monitoring phase. Much different, right? It's a smoother curve. Okay, so this curve doesn't last as long as the other one does, and it doesn't go up as high. And that's really, if you want to look at it from a schematic point of view, that's really what it's about. So does anybody know somebody had a lymphoma or leukemia? Okay, here. 50 years ago, not so long ago, right? And 60 years ago, we talked about leukemia or lymphoma as being a disease of the blood. That's what you were diagnosed with. They had a blood disease. 50 years ago, we talked about the disease as being either a leukemia with cells in the blood or in the lymph nodes, a lymphoma. By and large, it's the same thing. 40 years ago, 20 years from that time, 40 years ago, we had a diagnosis that we had chronic leukemia, acute leukemia, or pre-leukemia. They had either the predisposition for leukemia, they either had it acutely or they had it chronically, all right? Now look today. Look at the breakdown of the leukemias. Unbelievable, right? We went from a disease of the blood to 12 types of acute myeloid leukemia. This is all because we can identify molecularly what those leukemias are about. And that's why there's been so much progress in the disease, because we've been able to characterize it much better. Does everybody get that? Okay, so the percentage of patients whose tumors were driven by certain genetic mutations, we now know that there are certain genetic mutations, in other words, in the genes that we looked at 18 slides back. We now know, we've identified mutations that are responsible for melanoma. 73% of melanomas have a genetic mutation that we can identify. 56% of thyroid cancers have a genetic mutation that we can identify. And so on and so forth, all the way down. Look at lung cancer, 41%. So we can get targeted therapies to hit that act on particular sites. Now, this is a busy slide, but this is an example of why that's important. Look at this. I don't know if any of you are familiar with any of these drugs. Has anybody heard of Herceptin in breast cancer? For women that are HER2 positive, they get Herceptin. But the reason that Herceptin is given is because there's a biomarker, there's a site on the cell called HER2 Okay, without the identification of a HER2 site, there would be no Herceptin. We wouldn't know what it was, we wouldn't know how to work it, and we wouldn't know how it works or who to give it to. And you can see the progress, the unbelievable progress that's been made for all of these drugs. This is Erbitux. Erbitux is used, for instance, in colon cancer, okay? Erbitux hits epithelial growth factor receptor sites and the KRAS mutation site, okay? If people have these biomarkers, this drug will more than likely work. Here's Iressa. And here's so since 1995 there were 2, but look what's happened since 1995 all the way through 2012. All of these are targeted therapies. Tykerb works at HER2 positive, okay? So we might use Herceptin, and if that fails, we might go to Tykerb, okay? You follow that idea? It's unbelievable, right? So all this occurred from 1995 through 2012, and there's more of these drugs coming out all the time. Because of but what we need is a biomarker. You've got to have, this is a really important point, pharma is no longer looking for a drug that's going to kill all cancers. That's over. That ended. It's gone. It's over. What they're looking for is specific targeted therapies that will work. It may not work in all lung cancers, but who will it work in? Okay? That's where the progress is, and that's where it's going to be. So I'll end by saying this. This is anybody heard of Machiavelli, the famous Machiavelli? Okay. So here's what Machiavelli said. There is nothing more difficult than to take the lead in the introduction of a new order of things. For the reformer has enemies in all those who profit by the old order, and only lukewarm defenders in all those who would profit by the new order. This indifference arises partly from fear of their adversaries, and partly from the incredulity of mankind, who do not believe in anything new until they have had actual experience of it. Unbelievable, right? He's a bright guy. Not a nice guy, but a bright guy. All right, so how is breast cancer treated today? Well, if you look at 100 women who are so-called ER positive, node negative, all of them are treated with hormonal therapy. Of those patients who are treated with hormonal therapy, on average, 15 out of the 100 will recur within 10 years. If all of them are treated with chemotherapy, 4 of them will benefit, 11 will relapse despite chemotherapy, and 85 would have done fine without chemotherapy. So how can we determine which women will benefit from chemotherapy and which 85% will do fine without the chemotherapy? Good question, right? Well, one of the ways to look at that is through the San Antonio Breast Project, which we're running out of time. I don't want to get too deeply involved in this, but we can actually go on the computer and figure out what, based on thousands and thousands of women who have been reported with different treatments, what would be the best for those women. So if we look here, this is a 61-year-old woman, and you can plug these numbers into a normogram and it spits out a graph. Let's say this woman is 61, has been diagnosed with a very small breast cancer, under a centimeter, and she's very ER and PR positive, has a low-grade tumor, and is HER2 new negative. So she's ER positive, PR positive, and a really small breast cancer. Okay? Well, if we don't do anything, we just do surgery, of those women, who, out of 100 women, 88 of them will be alive in 10 years. Okay? If we give that woman hormonal therapy, we're going to save one more woman than we would have, so we'll be up at 89%. So the question boils down to, is it worth it to take 5 years of hormonal therapy if only you have 1% chance of benefiting? But that's a question that every woman has to decide on their own. Chemotherapy is of no benefit to this woman. Look at that. It's less than 1% of women who have a cancer this small, that's ER positive, that's postmenopausal, will benefit from chemo. All right? If you give combined therapy, in other words, chemo and hormonal therapy, you're not going to get much more bang out of the buck than you got from giving them hormonal therapy alone. So why take the risk of chemotherapy, which has a 10% significant risk associated with it? This is how clinicians make up their mind now, but there's a different way to do that. And that way is based on a company that first became commercially productive called Genomic Health, GHI. And what they do is, believe it or not, they can actually take the specimen that's already been looked at and is under a slide. Got that? All right? It's kind of like, what was that movie with the dinosaurs and they go on the island, and Jurassic Park. It's like Jurassic Park. They can actually look at the genetic makeup of that particular breast cancer. It's amazing, right? And look at the RNA expression analysis on paraffin-embedded tissue. So they take the tissue block, okay, that's already come out, and they can actually look at the RNA expression of that, and what they've come up with is this. And this is the way we now look at breast cancer. Okay? This is completely different than that slide I showed you before, which was based on the size and on ER-PR. This is now based on the genes of that particular breast cancer. It's amazing. And we're doing this test now. About 750,000 women have already had this test done on their breast cancers. And the chances are that if a woman is ER positive and has no negative, that she will have had this test done in the United States today. And this has just come about within the last 5 to 10 years. And look at this. This particular woman, despite the fact she had those good numbers, look at this. She's at high risk. She's in the high risk group based on the genes that she had. In other words, her risk of recurrence wasn't so low. It was actually 25%. And that's what we find, even though that based on the doctor tells the patient, and we do this, you know, you had a small breast cancer, you're ER positive, PR positive, chances are you're going to do very well. There is a small percentage of those women who are going to need chemotherapy. And it's not based on what the size was, on whether the ER was positive. Okay, it's actually based on the genetics of that breast cancer. And that's what doctors had a long time, some doctors had a lot of trouble understanding that and accepting that. But this is the way it is now, and it's the way it should be. Because we're going to save a lot more people by understanding what the genetics of their breast cancer are. So things are not impossible. This is a picture of the Boston Red Sox, who won the World Series in 2004. Okay, it was said to be impossible. They beat the Yankees in 4 games. They were down 3-0. They then won it 4-3. They then went on to win the World Series in 4 straight games. So it's not impossible. People thought it was, but they. Now, why do I spend so much time on this? These are my 6 grandchildren. All right, they're cuter than this picture, actually. And I'd rather see them healthier than I am, to be honest with you. That's my goal. And I'll leave you with this last thought here, because I think we covered a lot of material. And this is from a man by the name of John Richardson, a very bright guy. It says, when it comes to the future, there are three kinds of people: those who will let it happen, those who will make it happen, and those who wonder what happened. Thank you very much.